Okay, we're going to mark for breast augmentation. First thing that I notice and I look at with patients, I'm going to mark some landmarks, but everyone's asymmetric. So we're going to first mark her crease. I just like to mark the breast crease as a landmark. And the outer part of the breast, I like to mark the outer part. You can see this is where her natural crease falls right here. And it ends right there. So given that, you can see these folds are uneven. She and I talked about that you just have to live with that. To try and raise that fold is too hard. To try and lower this fold, you get what's called a double bubble. There's attachments from here to the ribs. And if we obliterate those attachments, the implant will migrate below what used to be the fold. You'll get a little bubble here. You'll have an indentation from what's her natural crease and then a bubble above, and that's called a double bubble deformity. The cure to even these is worse than the problem. So we just accept that they're asymmetric and that's how they are. The reason I'm so vocal about explaining this to patients is because when you augment a patient, you augment their asymmetries. So what she may not notice now is going to be more noticeable once we put implants in. And if they're ready for it, then it's not a big deal. They're still going to look great. Okay? The other thing I like to look at is I don't want to bring any kind of an incision past there. This is the outer part of the breast. These are just, for me, these are landmarks that just kind of square up and shape out the breast. Every surgeon's got their weird markings. I like to displace the breast so that I know this is the top portion of the pocket of her breast. That's the cleavage right there. So I'll just displace the breast so I can see where that is. The other thing I like to mark is, I usually put a few X's right here, and that's for a reason. I've been doing this for well over 10 years, and I still do this every time to remind myself, the pectoralis major muscle fibers, the pectoralis starts here, and it fans out on the chest wall, and it attaches to the sternum bone right here. We do not want to release these muscle fibers, because if we release these muscle fibers, the implant can then migrate across the midline, and we have then what's called symastia, or the unibreast. So this is just to remind me that when I go in through my incision here and I start dissecting this pocket, that when I get here, I'm not to release the muscle past this point. And that's kind of what this line is telling me, and what these X's are telling me is just stay away from that area. So it's always good to have visual during surgery to remind yourself, even though I've done this a million times and I know what I'm doing, I like the visual of, hey, remember, stay away from there. One thing that can happen to patients is if they're very active and they work out a lot is even though we stop here, they can tear their own muscles if they're not careful early on. And then you get what's called, the muscle just window shades up, and it just kind of contracts across the center of the breast. There is some degree the muscle fibers are attached here, and we do have to release those a little bit to allow that implant to settle down in the fold. Otherwise, if we leave the muscle attached, they get kind of a high-riding implant. In some patients, the muscle's loose enough that it will stretch over time, but most women need a little bit of releasing of those fibers in order to allow the implant to settle down and sit behind the nipple in a much better position. So this is pretty simple. Those are the only markings I do for breast augmentation. Any questions?
The only markings?
The only markings.